आप अभी भेज दीजिए ना सोसाइटी के ग्रुप में, बिकॉज टुडे संडे इवनिंग सारे को भेज दीजिए।
बोकारो एंड धनबाद, प्रतिभा मैडम यहाँ पे हैं तो
हाँ, एक बार सारे व्हाट्सएप ग्रुप में, सोसाइटी के ग्रुप में डाल देने से सबको एक बार रिमाइंडर हो जाता है।
हाँ, सब ग्रुप में डाल देने से, फॉक्सियन में, इसमें
हाँ हाँ हाँ, बिकॉज संडे इवनिंग है तो थोड़ा सा
डॉक्टर श्वेता ने
रिमाइंडर हो जाता है।
10 बजे तो तुम थी, 10 बजे जो हुआ।
गुड इवनिंग मैम।
अभी तो मैं
गुड इवनिंग एवरीवन।
हेलो
श्वेता बोकारो में सब
एवरीवन।
डॉक्टर श्वेता,
गुड इवनिंग एवरीवन।
यस मैम।
अच्छा,
The message is already in our JOGS group.
Yeah, JOGS group and Jharkhand group, we have the message ready.
Yes.
So shall we start?
Yes, ma'am.
Sadhana madam, Suchitra madam, shall we start?
बिल्कुल बिल्कुल।
Dr. Vikas, has he joined?
Yeah, I think he has joined. I just heard his voice. Just check.
Just let us start then.
Okay.
Sir is joined.
Yeah, great. Then we are the right time.
Good evening, ma'am. Good evening, everyone.
Good evening.
So good. So to start, good evening, ladies and gentlemen. I take this opportunity to welcome the gynecologists from all the 4 societies of Jharkhand, namely Bokaro, Dhanbad, Jamshedpur, and Ranchi. Since February is the National Cancer Prevention Month, this is the right time and the right forum to discuss about preventive oncology. And we have speakers and guests of national and international repute. We shall begin with the Ganesh Vandana. Yeah, over to you, Chitralekha.
Thank you, ma'am. Someshwar sir, please introduce ma'am.
Yeah, sure, Chitrakala. So, good evening, doctors. So, let me take the privilege to welcome our Master of Ceremony, Dr. Mosami Das Ghosh, who is a consultant at TMH Jamshedpur, and she is the organizing secretary of first All Jharkhand Ops and Gynec Conference 2016, and also she received Kamini Rao Orator is Zone, and Indumati is a very award, and also she had a publications in PubMed Index journals and Foxy. So with this, we welcome you, ma'am, and I over to you for the further proceeding. Chitrakala.
Thank you, Someshwar sir. Let's begin the program with Ganesh Vandana.
काम कर रहे हैं वेबिनार में है
गुणमंडिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि।
Yeah, I now welcome our President, Jamshedpur Gynae Society, Dr. Ranjana Joshi, for the welcome address. Dr. Ranjana Joshi, she is the President and she was the ex-secretary of Jamshedpur Ops and Gynae Society, a senior obstetrician gynecologist, laparoscopy and infertility specialist, trained in ultrasound, and she has various papers in national conferences and conducted camps in anemia and cervical cancer. Yes, Ranjana madam, please.
Good evening, everyone. A very good evening to all of you. It is a great honor for Jamshedpur Obstetrics and Gynecological Society to host this webinar today on preventive oncology. Preventive oncology is a special discipline in oncology that focuses on key measures that can prevent cancer development or delay the progression of the malignant process. Today's guests of honor are Professor Suchitra N. Pandit, President, Justices India Association. Professor Suchitra, welcome to this webinar. It is an honor and pleasure to have you with us this evening. I'm sure all your words of encouragement will help us progress in our webinar. Our second guest of honor is none other than Dr. Alok Devdas. He is the patron of the Jamshedpur Obstetrics and Gynecological Society. So we always feel that your guidance is of the utmost importance to our society. Dr. Usha Nath, patron of Ranchi Society, so warm, so knowledgeable, so enthusiastic. I just now asked her the same question. How do you manage to stay so sincerely attentive and enthusiastic throughout every webinar? We need your blessings for this webinar. Our main speaker this evening is the esteemed Dr. Sadhna, who is FOXI representative and ex-vice president, and many more accolades her name. I personally came to know her during our Brazil FIGO conference. You know, we actually did a trip to one of the tourist places together, and it was a wonderful, very nice to see you again. And then, of course, the moderator of the panel discussion on HPV positive, what next? Dr. Bhagyalakshmi Nayak, chairperson of the Oncology Committee. Bhagyalakshmi had come to Jamshedpur last year, and what a presence it was at our midterm conference. We always will remember you, Dr. Bhagyalakshmi. You really made our conference a super success. The panelists today are Dr. Nivedita Datta, one of the senior most gynecologists of Bokaro. Dr. Rupam, she is also from Bokaro. Dr. Meenakshi and Dr. Anuvi from the Ranchi Society, Dr. Sarita Kumari and Dr. Ruchita Sinha from the Jamshedpur Society, Dr. Abhijit Mandal from Dhanbad, Dr. Samir Hazra was supposed to be also here, but I think the evening he is very busy with another webinar. So overall, I would like to, last of all, welcome all the delegates. I hope this time on a Sunday evening, it turns out to be very fruitful, intellectually fruitful and valuable to all of you. I welcome each and every one of you today, and thanks to Shield Connect for hosting this webinar. Welcome everyone, and we shall now proceed, and I hand over to Dr. Motion.
Thank you, madam. Please join me in welcoming our guests of honor, Professor Suchitra Pandit. She is the FIGO Women's Awardee 2018, invited faculty for the last 7 FIGO conferences, President, Justices India Association, Chairperson of All India Cervical Cancer RCOG, President National ISOPAP 2018-20, President FOXI and ICOG, President Mumbai Society of OBGYN 2013-14. Welcome, madam, and we request you for your blessings and few words from your side.
Thank you very, very much, Moshmi. First of all, I would like to say a great big thanks to Dr. Nivedita for allowing me to join the JOGS group. And of course, I cannot, the very warm welcoming president of Jamshedpur, Dr. Ranjana Joshi, who's actually, hosting this particular webinar. I'm very, very grateful to you for inviting me. Yes, Moshmi, I had the chance of meeting Moshmi many years back at the SAVMA conference. And I've always had fond memories of Jamshedpur because we had Dr. Alok Devdas. I hope he's joined. He was the president of ISOPAB and the vice president of Foxy, and he was always into a lot of innovative ideas. And many a times we've had conversations with him. Thank you, sir. Thank you for always supporting the Jamshedpur Society and for also being like a role model for us. And what can I say about Usha ji? Usha ji, I mean, she is such a bright lady. So many years I've been observing her. The same enthusiasm, I agree with Ranjana, the same enthusiasm, the same, the keenness of understanding what is happening in our country and what exactly is going to be changing and what can we do to bring about that change. So I think hats off to Madam, Aapko Salam, because, it's not that just the age, but we just see that your blessings are very important for us, but also your presence, is a great source of inspiration for all of us. I still remember at the Chennai conference when I was handing over as president of Foxy to Dr. Prakash Trivedi, I had just misplaced my specs. And madam was there in the same taxi as me. And she said, Suchitra, mera chashma rakh lo, kuch kaam aa jayega, bhale hi kaam na aaye, rakh lo. And actually it served the purpose. And afterwards I found my specs and I gave it back to her. Said, nahi, ye rakh lo, ye mere, remember, keep it as a memory. So I still have that specs, ma'am. Thank you very much. And of course, I must say that as very rightly, Jamshedpur has chosen a very important topic. And we were just discussing before the webinar started, which way we can actually get our numbers of cancer cervix down. With the Preventive Oncology Committee working so hard, especially Bhagya. Bhagya is a great lady, extremely sincere and dedicated. I've attended her conference. And I know, she goes down to the grassroots and she talks absolutely simple language that everybody can understand. So I'm sure that she is going to have a wonderful panel. And Sadhna, another person who has been working with Foxy for several years. And it's not just Foxy, it is also her own local society, the UPCOG, the CEFOG, and now she's all poised, contesting for the presidential post. We wish you all the best. But Sadhna, keep up that dedication and the sincerity, because, we need sincere people. The country needs sincere workers like you. And of course, I must say a thanks to our chairpersons. Pratibha ji ke saath maine phone pe baat kiya tha. She's from Dhanbad. And I requested her, I said, madam, kaise bhi karke mujhe please nominate kar dijiye. Pratibha ji, thanks a lot for the nomination. And Suman Sinha, of course, I know her well because of ISOPAV, and she had done that wonderful, midterm conference at Ranchi, and she had taken care of so many small details. And Suman, all the best to you for your chairperson's contest too. And then I have to also say that all these young girls and young boys, I'm not saying young, when I'm talking about young, I mean younger as compared to me. They're all consultants in their own right. They're all going to be there for this panel, HPV positive, what nextness. And I like the way, you've selected people from all the 4 parts of Jharkhand, Nivedita Datta and Rupam from Bokaro, Meenakshi Kumari and Anuvi from Ranchi, Ruchita Sinha and Sarita Kumari from Jamshedpur, and Abhijit Mondal and Samir. And I heard that Samir is not going to be able to attend, but he's from Dhanbad. I had a chance to visit Chasnala and Dhanbad many years ago for a wedding. So I am familiar with those parts. I haven't visited Bokaro, but sometime in future, maybe I hope I can get a chance to do that. And once again, thanks to all the 4 society presidents and secretaries. I've already mentioned about Jamshedpur and Dhanbad, but let me thank the Ranchi Society as well as the Bokaro Society for having me over. And may promise karti hu ki I will wait till the end so that I can listen to all the topics that are going to be discussed. Sadhana is going to be talking about ovarian cancer, and Bhagya is going to be taking us through the preventive oncology of HPV+. And once again, thank you very much. Thanks to Stavan. I love that name, Stavan, Isha Stavan, who helped me to get the last minute connections. Thank you very much. And once again, Usha ji, आपको प्रणाम. और sir मुझे दिख नहीं रहे. I need to see sir's face.
Sir is there.
I'm not able to see him. But sir, a big namaskar to you also.
Thank you, Suchitra. Thank you for kind words for me.
Sir, you are muted, sir. Please unmute yourself. Devdas, sir, please unmute yourself.
Thank you, madam.
Maushami, sorry, मैं एक बात थोड़ी.
Yes. Yes, अभी sir को ही बुलाएंगे. So we'll
I'm also contesting for the Foxy representatives post of FIGO. My only sincere request is, please, all of you register with the member.foxy.org so you know your eligibility to vote. This is open till 10th March, and 3rd week of March, the elections will be there with the president, vice president, and the Foxy representative. Please, zarur vote kijiye aur support.
I'm all ready. I did it.
We all have, I have done, and I have requested my society to do it also. Madam, you are all for you. Don't worry.
Yes, madam. And hope Jharkhand finds a place after you are the Foxy representative.
Yeah.
Yes.
I think we are all for East Zone here. All of us representing East Zone here to Dr. Suchitra.
You're so familiar to Suchitra Pandit, madam. Long back, madam, do you remember you had come to our institution at IACM?
Yes, yes.
And you had taught us how to do cesarean in a floating head. And I do remember, whenever I do, I remember you. So you're always in my thought.
Good evening, ma'am. Good evening, ma'am. I'm Dr. Nivedita. Ma'am is always.
Hi. Hello, Nivedita.
I thought of not interfering initially.
Hello.
Yes, good evening, Usha, ma'am.
No problem.
Namaste, pranam, ma'am.
Alok sir, namaste, Nivedita, Dr. Vanita.
I think, sir.
Good evening, Dr. Bhagya.
Good evening. Good evening.
Yeah. Devdas sir, yes. Next, our patron, Dr. A.K. Devdas. He was the Vice President Foxy 2006, President ISOPAP 2004-2006, Chairman of Indian College of Obs and Gynae 2012, peer reviewer of various international journals, Corion awardee, author of several textbooks, examiner, and his innovatives are paperless partogram, growth tape, and descentometer. Sir, a few words from you.
Sir, yes.
Is it audible and visible?
Yes, yes.
Okay.
It's audible, sir.
Yeah, audible.
First thing that I like the topic that you have picked up, preventive oncology. That's where we have to concentrate. Treating we are doing, we have done enough, but main concentration has to be like you have chosen, preventive oncology. Just one thought I want to give from my observation over the years, that all these meetings, these and many others, many things will be talked and we will praise the speakers, but ultimately, whether it is going to the woman at large, I have my doubts, and I don't know whether I should say that pap smear facility is not available in most places, including my town, Jamshedpur. I send patients to have it done. They go from pillar to post. Nobody will do it. And even on payment, it should be free, but even that's not there. So all these big things we are talking about is ultimately not implemented. It depends at this science level and talking level. So I wish after this meeting, well, the people responsible should take up and make the screening available and preferably free. Well, that's all I have to say. Thank you.
Thank you, sir, for your blessings. And we were all waiting for you to join. So we were happy to see you.
Thank you.
Our patron of Ranchi Society, Dr. Usha Nath, madam. She is the medical director of Nath Hospital, Ranchi. She has worked in cervical cancer prevention and management, contributed to workshops, contributed to publications on the topic, and she has several research on cesarean section in relation to maternal well-being, as well as colposcopy in conjunction with visual inspection of cervix. Madam, please, for your blessings.
Thank you, Mosmi. Thank you for your kind words. I am really very honored to be guest of honor of this conference of JAGO upon the preventive oncology. This is a topic which is very much near to my heart and my interest both. And I want to say that sharing this conference with Dr. Suchitra Pandit, Dr. Sadhna, Dr. Devadas. Dr. Devadas, I remember you. Whenever I met, he's very respectful and very, very worthwhile time I had in conferences and other places whenever I met him. So it is really an honor to be amongst them. Other Moshmi, Ranjana, Suman, all they are, and Nivedita, not forgetting Nivedita and all being here. It just looks like, feels like family. And this topic is very, very important for us. What we have done so much, as I was saying a little bit earlier, that what we have done and done so much hard work. When I returned from abroad in 2001, the first thing I did is opening the colposcopy clinic. This is the first colposcopy clinic in Ranchi, and the first colposcope, I got it, Olympus. And done so many workshops here for the doctors in Muzaffarpur, in Patna, in Dhanbad, in Bokaro, everywhere I have gone in our Jharkhand area and also Muzaffarpur and Patna. What I feel everywhere after doing all these things, that we really are working hard towards it, but it's still why we are not getting it under control, like in Western country where they followed the smear screening, and the incidences of cervical cancer come so much down. What I feel that we are working in the awareness devoid, and our work is in, I'm sorry to say, in a haphazard manner. We are working hard, but it is a bit haphazard manner. And that is what I want, that someone should have a systematic way, the government should be involved, and they should make a system like in Western country, that the vaccination is included in the pediatric vaccination and that sort of thing. And also the awareness should not only be for the screening, but for the lifestyle, a better lifestyle, quitting smoking, improving vaccination strategy, and screening methodology, finding a newer cancer markers. All these things will help, I think. And we should also work towards that, as Dr. Devadas said, that we are doing all the conferences and everything, but it's not coming on the ground, to the women. Our knowledge is not being transmitted into practical purposes. So we should look into that also, and we should do something about it. People should get it together and form some strategy in this. So thank you very much. I also want to say about the topic. Topic is, although the old topic, but it's in a new form, like Dr. Sadhna Gupta is going to speak upon ovarian cancer update and screening. This is something, important. It's a deadly cancer for the women. Although incidence is lesser, but when it happens, it is only diagnosed in advanced stages. So it's a very, very important topic. And the other HPV and all these things is also very important. And as Dr. Suchitra Pandit said, the newer generations are coming up, and they are the one who will take our works forward and help the society. So thank you very much again, and welcome to everybody in this, whose name I have not taken, but they are all in my heart. And I really welcome them very much. Thank you.
Thank you, madam, for your blessings. Now move on to the session. The session 1 is on ovarian cancer screening updated, recommendations and status. We have chairpersons, Dr. Pratibha Rai. She is, next slide, please. Professor Dr. Pratibha Rai, she is the president of Dhanbad Obstetric and Gynae Society. She is the HOD of PMCH Dhanbad, a very nice and sweet person. Next. We have Dr. Suman Sinha, president of Ranchi Society. She is a senior consultant and infertility specialist and director of Advanced Care and Maternity Center, Ranchi. She is zone coordinator of medical disorders in pregnancy, vice president SOFSI Bihar and Jharkhand chapter. Over to you, madam, Dr. Suman Sinha and Dr. Pratibha Rai, to start the session.
Thank you, Dr. Mausami, for your very generous introduction of mine. And good evening, all the faculties and the delegates. I, Dr. Suman Sinha, bring greetings from Ranchi. And now, after the very lovely inaugural function, we move on to the academic session. And as we all know, this February month is Cancer Awareness Month. So we have rightly chosen the topics. And for this session, we have a very eloquent speaker. We all know her. She is none other than Dr. Sadhana Gupta. And Dr. Sadhana Gupta, as we all know, she is embodiment of knowledge and excellence. And she has strived very hard and has achieved a very respectable position in Foxy. And now she is contesting for the highest post, and that is Foxy president. And we all wish her good luck and good wishes from all the Jharkhand society. And regarding her introduction, I'd like to say a few words about her achievements. Can I have Madam CV, please? Okay. I have written something, so I would like to say. Madam has been representative to Shakao between 2018 to 2021, and she is ICOG Governing Council member 2015 to 2021. She has been Vice President Foxy during 2016. She has received the Best ICOG Governing Council Member Award in 2021. And she is a recipient of Mr. N.A. Pandit and Mrs. Sanja N. Pandit Women Empowerment Award in 2020. And she has been chairperson of Safe Motherhood Committee and also Vice President Foxy. So, Madam, over to you, and you are going to speak on a very pertinent topic, that is within cancer screening, updated recommendation and status. So, the floor is yours, Madam. We invite you for your talk.
Thank you, Dr. Suman, for kind introduction, and I owe a big gratitude for this opportunity to be with all Jharkhand societies, and my all pranam to all stalwarts whom they have been the part of journey. Dr. Alok Devdas, inspiring person, always there in our all academic activities. We have done any activity when Dr. Alok was not part of it. Dr. Suchitra Pandit, so much a long journey, long association, and how we really know the people and how they motivate us in our journey and how to organize things. Dr. Suchitra Pandit has been a close abide, and Dr. Usha Nath, teachers of teachers, very vigilant. And what we said, that there is no way to escape. So always we have to keep on our toe that we are on your expectation or not. And there is all my pranam to all president and the secretary of Ranchi, Jamshedpur, Bokaro, and Dhanbad societies, and our loving youngsters, Moshmi, Ranjana Ismail, and what she was remembering, that was the trip to our Christ, and we were really lucky to have that all Christ in the full glory and the Rio. It was something wonderful. We really remember it. So with this, that is a preventive oncology, and it is a cancer oncology month. And really, I'm privileged to be with Dr. Bhagyalakshmi too, who has done a ground root level, and what Foxy gives you that platform that we really have the people of metal and dedication in our association. So I bring greeting from Foxy Sapog ICOG Journal, whom I have served in various capacities. And it is Jharkhand, it is Jamshedpur, the city of Tata. Dr. S. Das Gupta has been a proud person that who has been president of Foxy and a known international figure while working in a place Jamshedpur. And what Dr. Ushana saying, that actually we need that excellence level like Dr. S. Das Gupta, Dr. Alok Devdas at every corner of the country. So then only the health and the good practices will reach to all people. So this is one thought process where we are lacking, that we are not having the equal representation even at very various platform. मेरा श्रद्धापूर्ण नमन परमहंस योगानंद जी को, जहाँ पे डॉक्टर उषा नाथ और रांची सोसाइटी की कृपा से मुझे बहुत बार जाने का मौका मिला है. And autobiography or GRD Tata and Paramhans Yoganand-ji, both are my favorite. Like whenever I'm in trouble, we can like learn from the two diverse aspect of the life, and actually they merge at one point. That is serve people with compassion and love. Actually, it is that is compassion and love that makes our work going and keep us going. These are few fond memories when Dr. Devdas took me to the trip of city of Tata, beautiful city. And what was the great occasion that we facilitated all the societies, facilities who have joined Manyata project, that was M4M that time, and given the Utkrash certificate to all facilities who have joined, and Nivedita is with us, Ragini, Moshmi, you can see. And these are it is asset of working for the Foxy and working together as a professional. So with all these fond memories, my gratitude and the love and compassion to all. The value of experience is not in seeing much, but in seeing wisely. So coming to topic, ovary. I possess a mysterious physiology that affects all organs from head to toe. It is for the vigilant clinician to decide they want me as a friend or foe. Hope in next 20 minutes, we will take ovary as a friend, and we will recognize when the ovary is angry and when we have to intervene. So ovaries are something most mysterious and the least accessible of female reproductive organ. And nature has designed the female reproductive organ to be less accessible. They have the intricate relationship with every organ of the body, and we can have myriad of maladies arising from in their like malfunction of the ovary. It may be PCOS, it may be adnexal masses, it can be the cancer of the ovaries. And while it is a relatively inaccessible, that lead to detection of ovarian disorder, which include borderline tumor as well as ovarian malignancies. So what is magnitude and impact of ovarian cancer? Actually, it is neither common, but it is not rare also. And that makes the thing quite difficult for the health program to organize. Still, we have around 250,000 cases every year in the world, and with 125,000 deaths. So a good number of mortality is there. In Asia, we are a little fortunate that we have lesser incidence of ovarian cancer. So it is like something, a balance that we have a little as a race. But as a per population based registry, ovarian cancer is one of the 5 leading sites of cancer. And from 1990 to 2016, the incidence rate of ovarian cancer has increased substantially by 28.6%. So it is on the rise, and we have to be ready with it because of many, many lifestyle modification and ways of life in our country also. It remains the most lethal gynecological malignancy. An important thing is that when we have early detection or when the disease is confined to one ovary, survival rate is up to 70 to 90%, but in advanced disease, it is 20 to 30%. And that's why the professional bodies and science is working that if we can detect ovarian cancer early, that is only best hope for the mortality reduction as well as long-term disease control. It is classic classification 1, 2, 3, 4. And epithelial ovarian cancer is the most common form of the disease with the 46% survival rate. And again, I emphasize that for localized cancer, the survival rate is up to 90%, but this distant spread, it is around 20 to 25%. And we can prevent mortality by prevention, screening, early detection, and optimal management. Now, ovarian cancer, the family history is very, very important, but somehow in our practice, we actually are not tuned to take the family history of every gynecological or every woman that you have any history of ovarian, breast, or colon cancer in the family. Because the most well-proven risk factor, that is around 3% of ovarian malignancy, we have the family history either in the first degree relative or sometimes multiple relative. Then inheritance of delirious genetic mutation, and 10 to 15% of ovarian cancer occur with the women with BRCA1 and BRCA2 gene mutation. And the next points are why we are having increased number of ovarian cancer now, because there is a rise in obesity. And for every 5 BMI, there is 6% significant rise of the risk factor of ovarian cancer. Nulliparity, every childbirth reduce overall ovarian cancer by 6%. And now we are having a lot of infertility issue. Tobacco smoking, and one is iatrogenic, that use of postmenopausal hormone therapy may also increase risk of ovarian carcinoma. And as per, I am a strong proponent that we should do the postmenopausal hormone therapy, not now, since 2000 and 2002, when the many bodies were really advocating postmenopausal hormone therapy, that it should be only when needed for the shortest time and for the very, very well selected and well monitored patient. So nulliparity, early menarche, late menopause, increasing age, all are there in our society on the rise, and that's why we are going to have a rise of ovarian cancer risk also. And what is the protecting factor? That is combined oral contraceptive, pregnancy, lactation, and tubal ligation. So there are the promotive factor, and obesity, diet rich in fat, smoke, alcoholism. It is in our hand that we can do good lifestyle in our society. Then family history, genetic mutation, it is in the genes, and hormone replacement, it is for us to take care of it. And few things are not in our hand, that is early menarche and late menopause. With this screening and preventing strategy, and what is an ideal screening test? It must be inexpensive, it must be easy to do, not discomforting to patient, reliable, valid, sensitive, and specificity should be high. And the screening program should be designed to that population who have the high prevalence of disease, so that we can have a good positive predictive value. And when we organize certain screening program, it must show improvement in morbidity and mortality in that vulnerable population section. Unfortunately, for screening of ovarian cancer, we don't see an ideal test still on the even horizon of medical world. Most women, why it is different? Because it is different. Most women diagnosed with ovarian cancer have sporadic variety, neither common, not rare. And there is some section has got the familial fashion, and for this section we will have a different guideline. We have to frame different guideline, and we must be aware of all genetic predisposition. And the highlight is that the cumulative lifetime risk of ovarian cancer is 40 to 50% for BRCA1 and 20 to 30% for BRCA2 and 12% for the HNPCC. So these women need a totally different screening protocol than from the general population, and that makes the subject a little bit complex. So these are all risk pattern and who should be monitored, and it is all based upon the family history and the genetics. Besides this, it has got its own challenges. The prevalence is around 1 in 2,500, and that is in postmenopausal women. So if we want an effective screening, it must be having the positive predictive value of 10% minimum. Secondly, because it has to be confirmed histopathologically, even 10% positive predictive value will result into the 9 unnecessary surgery. We don't know the histological precursor lesion like CA cervix. We don't know what is the time from the stage 1 to stage 3. Most biomarkers are evaluated in advanced cancer, so we don't know what is value in the normal population in different age group like perimenopausal or postmenopausal, and we need a very large prospective cohort because it is around 1 in 2,000 to 2,500. Now, few things I want to give clear message that we must understand in 2 type of cancer, that is type 1 and type 2. And type 1 is totally different from the type 2. It is indolent while type 2 is aggressive. Genetic mutation instability is not there in type 1 or very low, but it is very high in type 2. Histological subtype are endometrioid, clear cell, mucinous or low grade serous, while in type 2 it is high grade serous. We have the precursor in type 1, that is benign cyst, endometriosis, a small cyst. And the type 2, the de novo starting, we don't know where it originates, and we suspect now that it is a series of tubal dysplasia. So we don't have a precursor in type 2, and fortunately in Asia we have much more type 1 than type 2. So in few respects we are quite fortunate also, and I always believe that the nature is always a balance. So what are the challenges? These are the difficulty, and always we like to overcome all the challenges and what we can do in our clinic. Dr. Sir Devdas says very rightly that pap smear, contraceptive services, these are the thing which has to be felt actually, Arti. Whatever we know, a very, very complicated thing, what I totally, like in accordance with the view of Dr. Devdas and Dr. Usha Nath concerned, that we may be very, very highly expert, but if we are not reaching to those people who need it, really respectful pap smear, call back, and so many things, respectful ultrasound, knowledge about that this thing can happen in postmenopausal women, that actually that knowledge is not going to translate. And that's why what Tata says, that always work with the love and compassion for our own people. It may be tribal people, it may be rural people, it may be not paying people, or it may be well paid people, but actually we must have our own professional level at the quite a emotional and the compassionate level, and that is the crux of everything. So what we can do in our clinic, a complete gynecological examination. One very important, whenever the particular woman, especially perimenopausal or postmenopausal, complaint of bloating, pelvic or abdominal pain, change in bowel habit, change in appetite, fullness, please consider that it can be the ovarian pathology, because they go to GIT, gastroenterologist, sometimes they say they are psychological, they can be even prescribed the tryptomar or something antidepressant, but we must know that we should listen to patient, that they are having constant problem, and we really see the patient only like a gastric patient, gastric or less of appetite, and you see a big or a moderate size ovarian tumor. So listen to patient, one thing, but the clinical examination, now we are not so good also. The young generation is going less and less for the clinical examination. And just now I will say Dr. Kamal Bakshi says the patient also don't want to lie down for examination. So per speculum examination is also missed. So what the UPSTF study says, that by clinical examination, we cannot actually diagnose or detect ovarian cancer, and it has not been found that it can be any screening procedure. CA 125, I see the investigation ordered even from adolescent girl to reproductive age, but CA 125 is notorious that it can be high in many benign conditions. And CA 125 single value is not that important, but the age consideration and the repeat value, when it is on the rise, then it can be a good screening method, but it adds to cost. And if this screening procedure is useful or not for general population, we will just see. A word about the pediatric or adolescent early age cancer or the reproductive age ovarian malignancy. These malignancy can be dysgerminoma, and they don't have the increased level of CA 125. We should be careful about it for pediatric or adolescent or sometime in reproductive age. Then we have to go for the other tumor marker, that is AFP, LDH, and beta HCG. Ultrasound, we can see now, visualize ovary very well with the transvaginal ultrasound. And it has got a good sensitivity and specificity, around specificity of 98.7% and PPV of the 14%. And the criteria using is that more than 10 cc in postmenopausal women and more than 20 cc in premenopausal women. That should be the criteria that we can take it as a screen value. But we must be aware of it, that we must have a memory of iota and the malignancy index, and they are very simple. As a clinician, it is I think, and we plan and we suppose that most of the gynecologists do their own ultrasound, so that we can really do repeatedly and we can do a close follow-up, because single ultrasound cannot give many times that what is happening it, and which women need the follow-up, close follow-up, and which women need the further checkup and further screening and the testing. So this is the iota rule, that is benign and malignant rule, very simple. And any tumor which is irregular with ascites, with a larger size and a good color flow and a papillary structure, then we see it is malignant and must be referred at right time. So likewise, the ultrasound index of malignancy, which add premenopausal and postmenopausal, because being postmenopausal itself comes as a risk factor for the ovarian cancer. So the greater specificity can be achieved by the use of CA 125 and ultrasound. And we must, one message I want to give, not like fix on the one value, but the repeat value or the follow-up of CA 125 as well as follow-up of ultrasound is important. Now, this is our clinical practice, which few messages we have got, but what is the research and evidence say? It puts more question or it answers our question. I will just share, it is up to you to think over. So these are the three modality: examination, TBS, and the CA 125. And we have got one big trial which have assessed the screening modalities efficacy. That is PLACO trial. It is done around 78,000 women between 55 to 74 years. And they say that this trial actually did not change the expected stage distribution from unscreened population, and PPV was only 1 to 1.3%. Then United States Preventive Service Task Force, it evaluated whether it is useful or harmful, and again say that screening for asymptomatic low-risk women in postmenopausal women is not beneficial, because they found no mortality benefit and harms in form of false positive screening result and subsequent surgery. UK CTO trial done in around 2 million women, and they were randomized. One is CA 125, one is CA 125 with ultrasound, and they followed it. And again, they didn't find any significant difference in mortality in the three groups. And what is important is that when they used CA 125 or CA 125 with ultrasound, they have got the 3.1% and 3.25% surgery to confirm the ovarian malignancy, which were negative finally. So screening test positive, it was confirmed with surgery and they were negative. And out of these, 15% of these women had major surgical complication. It is postmenopausal women, they must be having some comorbidity or what the surgeon did, and sometimes we expertise in what level, but 15% of these women had major surgical complication. And the psychological harm for call and recall, few studies says that it is not that psychologically, but few studies says that they are really worried because they are being recalled again and again for the confirmation and for the surgery. Cost effectiveness, today the world is for all economics. If we are talking right from profession, like we are the little older generation, but new generation, all for economics, and world is for economics. And it shows again that it is not that cost effective, because the multimodal screening with no screening, the quality of life here, that is 8864. So it can be potential harmful. So does screening help in risk reduction? It again says that the CA125 TBUS in asymptomatic low risk women, it is not that useful. ROCA based like repeat and the CA125 label can help. So American Cancer Society, ACOG, because this trial has been done in UK and USO and in a large population, and they have given two things, that for asymptomatic low risk, no general screening we can advise, but we can have different guideline for a woman with risk. Not only the genetic mutation, but with the family history like nulliparity, diabetes, obesity. So what have been the aggravating factor? These women we can consider for the screening, that is add-on screening for it. Now, always, we must have always we must have a question. Like our teacher says that why we are not getting this result. And when these recommendations were put for the comment, there were many voices against it, that ovarian cancer is a very aggressive thing, very high mortality, and they don't agree to it, that it should not be in our health program. Then UPSTF replied it that we are not considering the cost of screening, but we are considering on the basis that it is actually not effective screening methodology we don't have, and it is not effective in low risk asymptomatic women for doing routine screening in our health program. So the dialogue is still on and it continues. And again, what say the all ACOG and the National Comprehensive Network issues that we must have a different guideline, women with having the hereditary predisposition or having high risk factor, and they have a little bit revised it. So coming to this one message, that for all postmenopausal women, we cannot place like a cervical cancer screening or a self-breast examination, but we have to be careful to take history. High risk women we will take, one is the family history of the cancer, but the second is all aggravating factor, what we have said, that is obesity, comorbidity, alcohol consumption, the early menarche, and we have to take, and the small family size. Coming to high risk women, are they totally different? So it is all in our gene, and we know the 10% of all epithelial cancer have the 90%, they can have the contribution from BRCA gene, BRCA1 and BRCA2. So only 1% of healthy women in general population have abnormal rise of CA125. So again, we have discussed, but the women with the history of ovarian cancer in first degree relative have 5% risk of developing ovarian cancer. So it is from 2 to 5% if there is a history of ovarian cancer in first degree relative. Hereditary site specific syndrome. So one message, that first degree relative, second degree relative, and you have to be patient in your OPD. आपको घर में, even in the male counterpart, they have any bowel cancer, ovarian cancer, breast cancer, and we must be very particular about taking this history. And we know that the patient with specific breast ovarian cancer syndrome should be offered genetic counseling tests for BRCA1 and BRCA2. Now we think that the BRCA1 and BRCA2 we cannot do, but actually if the patient is having that strong family history, we can really take advantage of technology like HPV testing, and something that it is available and it should be offered. And if they are carrier, Then they are recommended annual rectosigmoid vaginal examination. Everything matters now. Annual CA25 and TBS till age of 35. And when they have completed their family, prophylactic bilateral salpingo-oophorectomy is recommended. So very, very important message, family history of breast, ovarian, colon cancer, offer them the genetic BRCA1, BRCA2 mutation testing if they are positive. Follow them right from age of 30 years, not in postmenopausal, and after 35 years, when their family is completed, prophylactic salpingo-oophorectomy is recommended because chances are very, very high in BRCA1 and BRCA2. And oophorectomy, when we do it, it also reduces the risk of breast cancer as well. So they are totally different. And for BRCA1, the salpingo-oophorectomy is recommended 35 to 40 years. For BRCA2, 40 to 45 years. For Lynch syndrome, 45 to 50 years. And it is important to note that hysterectomy is recommended in addition to salpingo-oophorectomy bilateral in Lynch syndrome, given because there is increased risk of endometrial cancer also. So this is very, very important surgical technique. Opportunistic salpingectomy is a big talk in the last FIGO and something, because they are having type 2 cancer also. So they think like the Western world has more concern about the tubal origin of cancer and the BRCA1, BRCA2 mutation. Definitely these patients have the risk. So it is a good, it is a like technique to be learned right from fimbrial end to interstitial end, and don't disturb the ovary. So when to refer, just point, because now it is a institutionalized care, it is time, and then we should refer to oncology unit. One clear message: whenever the premenopausal woman CA125 more than 200, ascites, distant metastasis, family history of cancer, breast and ovarian cancer in first relative, refer to oncologist. And postmenopausal, when CA125 is 35, ascites, nodular or fixed pelvis bulb. So we must have the clear idea that this patient we can deal in our own setup, and this patient need the institutional care. What is way forward? Very ample research is going on, because it is a dreaded disease. And we all know when we put a 60-year-old person on ultrasound, we see a big ovarian tumor. Like it always comes at this age, that much of agony, that much of treatment agony. And the world also is like, we are really concerned for it. In SAFOG region, what we can do? We are not rich people, but we are much ahead in thought and philosophy. That is my way, because I think we are much ahead than Western world in many, many ways. What we can do for our people, because public awareness for good health, that is the important thing. With COVID, health has come into main front. And as a professional and as leadership, we should take this advantage to keep up health on top agenda, maintain healthy body weight, avoid or quit smoking, encourage breastfeeding, encourage good contraception, like COC have got occupational safety hazard, very, very important, and vitamin D supplementation in deficient women, that has also been a little bit caused in the etiopathogenesis. Future direction, we say 35-year bilateral salpingo-oophorectomy can be quite a quality of life issue. So we can consider salpingectomy first and the delayed oophorectomy, but we don't have the long-term data. Tomorrow's medicine for the genes, and we will remember genes, and in the future medicine like PTX2 overexpression, STNA, and it is our Indian ways of thinking that our, like now we say that it is in our genes. What we say, it is a weight gain, it is disease, or it is health also. So the science is also coming on to that point, and whenever we will understand more about genetic expression, maybe we will have the more target treatment strategies for ovarian cancer. Finishing the talk with the vaccine simulating immunity to milk protein, core protein, that has been found effective against breast cancer, can be effective also against certain ovarian tumor, and that is also way the genetics is future way of medicine, and vaccine is future way of medicine, and prevention is the way of future medicine, and we are here for the preventive oncology. So we see prevention as a best cure. And our problem is much, much more in equity, equality, and accessibility. It is in life, it is in healthcare. And we know now that if one is unsafe, everybody is safe. If Ukraine is unsafe, we all are unsafe to the nuclear war. If one have the COVID, we all can have the COVID. And there is the thing where our civilization has put us. We know technology, we know science, but we have to reach the people. And that should be our first concern. It is what we respond to the challenge, which our experience have put before it. So what I again quote with the Jharkhand society, the beautiful saying of Tata, to be a leader, you have got to lead human being with affection. Hearty thanks for joining in journey. My also warm affection to Dhoni, because somebody I thought from 2 or 3 people that you have become like a Dhoni. And nothing worthwhile is ever achieved without deep thought and hard work. And it is going to be continued. Hearty request for your full-hearted support for my candidature for Foxy presidential candidature. Thank you very much.
Wonderful. Thank you. Wonderful. Pratibha ma'am, if we could have your...
Yes, am I audible?
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
Good evening, everyone. It is my privilege to say something after such a brilliant talk by ma'am, Dr. Sadhana Gupta. And really, madam said that ovary is most mysterious and less accessible of the female reproductive organ. Till now, we all know that ovarian tumor always give vague symptoms till it becomes malignant. And now, like pap smear, we have nothing to diagnose very earlier, except if patient come to us with some vague symptoms. So always we should keep in our mind that anything can happen to the patient, and always take a proper history. As madam said, always take a proper history to diagnose ovarian cancer, whether her family history is affected or there is any history of breast tumor in her family or mutation of gene like BRCA1 and 2. So just examining must take a proper history regarding the cancer. And there are so many markers besides CA125, as we know that it is higher in mucinous cell carcinoma, but other tumors are very common, like germ cell tumor and stroma cell tumor. So we should also keep in mind to look for beta-HCG, LDH, alpha-fetoprotein, AMH inhibin, and just after 35, we should be very alert. Always take, if a patient comes with any type of problem, must do transvaginal sonography. And if there is any tumor, ovarian tumor, whether it is benign or malignant, to rule out it, we should do CA125 or any related germ cell tumor. And as madam said very nicely, that proper screening is must. Proper screening is must, and high risk case should be give a special weightage to proper screening. And only by this we can minimize the ovarian tumor to a less. And one new thing we came to know, that if patient is susceptible to ovarian cancer or her first relation or any family history has suffered from breast cancer or ovarian tumor or anything, at the age of 45 or 35, we should do bilateral salpingo-oophorectomy. A very good thing we come to know. Thank you, madam. And we are all giving you votes.
Thank you.
From my side.
Thank you. Thanks for the kind words.
Best of luck, madam.
Presentation, Sadhana. Wonderful.
Thank you, Rajna.
Do you ask the question now or later?
Moshmi, we can quickly have a couple of questions.
Yes,
One
and then we'll go.
one simple question.
Sadhna madam is all in our society. Like she's always traveled to Jamshedpur, Ranchi. Like she's very close to each one of us here.
Yes.
Yeah, true. Very true.
Very
I have so many times to Ranchi, and she had a very beautiful workshop on BPH. Remember long back, and then she conducted a Allahabad. We all were there.
And 2 times madam's blessing, 2 times inspirational paper. So that is one of the unique thing which Dr. Ranchi Society and Dr. Usha Nath gave me about the inspirational paper.
But you speak so well, Sadhna. I can't do anything else but this. Yeah, I have a question, Sadhna, on this topic. If I may be allowed to ask this question.
Yes. I take liberty, yes, from
You spoke very much about this ovarian cancer, and actually, as we know that is, when we diagnose it is too late. In only some people we can diagnose in early stage where we have opened the abdomen for something else. Now, even the screening is difficult because that is not very, indicative that ovarian cancer is there. On the other side, ovarian cancer symptomatology is not the same. It's always different from one to another. Now, my question is that what do we do? We have to find a new way that we can single out ovarian cancer in early stage. And second question is that is there polycystic ovarian syndrome has any connection with the increased risk to ovarian cancer? So these are 2 questions.
One question is, madam, I say that one thing that ovarian type 1 cancer are a little more common in India than type 2. So my takeaway to all the people that whenever we have endometriosis, follow them with the we are treating again and again only infertility, and sometimes pain, but follow it that the endometriosis cyst, what you are following, suddenly it can have a different picture, especially the variegated appearance, papillary structure, and then consider on the line of malignancy also, like the repeat CA125 value and the other marker, especially the size and the iota index and the RMI index. So any benign cyst, it is we have the follow-up flow chart sort of thing, that if it is 4 to 5 single cystic, we can call after 3 months, in whom we should call after 6 weeks, and which patient to be followed. And we can do only then we are well versed into the transvaginal ultrasound, because ultrasonologists have got their own perspective, and many times few are very good, but they are very, very busy. And we should be expertise, because we really know that now this ovary is not looking well. So one thing is that type 1 clear cell carcinoma mucinous, which adnexal mass is to be followed closely, and which adnexal mass we can reassure that it is simple and it is okay, it is physiological, you can do 6-month ultrasound. And secondly, about polycystic ovaries, what the research says, PCO itself is not a precursor of ovarian tumor, because it is a ovulation difficulty, but repeated ovulation induction in these patients, they have the question mark on it, and we are really concerned for 2 malignancies with PCOS, because people 10 cycle IVF, 8 cycle IVF, unlimited cycle of ovulation induction, then both cancer, it can cause sometime risk of the ovarian cancer as well as the endometrial cancer, because people are putting on IVF, and the patient is having an endometrial hyperplasia, big 13-15 millimeter, and we should be careful. PCO itself has not been found for the ovarian cancer, but repeated ovarian stimulation, there is a question mark about it. And we must have the limits of the ovulation induction cycle. It is 3 done, 6 done, maximum 12 in a lifetime, but not then that it. So our we should be very careful about that spectrum of practice and the gynecological practice also.
Exactly. This was the reason in my mind to ask you this question. So,
ma'am, sorry for interrupting, but Dr. Bhagya is also here with us, and she has been the chairperson of oncology.
Wherever the IVF patients are there, they should be put in high-risk group to screen them for ovarian.
So we can take her opinion.
Yeah, thank you.
Welcome, Nivedita, and
Would you like
Bhagya,
to
your opinion. Yes, sir, Doctor.
Yes.
First,
Dr.
Dr.
Lakshmi.
First, Dr. Devdas, and then Bhagya.
Yes.
Yes.
So,
Sir,
yes.
yes.
I shall I start?
Yes, sir.
Yes, sir. We are waiting.
Audible, sir.
Yes.
Some suggestions on prevention of CA ovary based on statistics, some of which Dr. Sadhna mentioned already. One is OCP prevents taking it for 3 years continuously.
Yes, sir.
So we know this.
But we can't hear you, sir.
Hello.
I think he has lost the signal, no?
No, Dr. Devdas was just mentioning about OCPs for 3 years.
Yeah, yes, sir.
So that causes 30% reduction in risk of ovarian cancer, also colon cancer. And second, after she has had 3 years of OCP, she of course does not want any more issues. So she should have lab TT routinely. The reason is, one theory is there that those women who had TT has much less incidence of CA ovary than those who did not have, because it is proposed that some element, maybe from coitus, maybe some virus going through the tube, entering the ovary, and especially every ovary has every month a scar, that ovulation scar, enters there and causes CA ovary. So after 3 years of OCP, the women should go for
lab TT. Okay. So two very important inputs have come in. Nivedita? Yeah.
And Bhagya Lakshmi.
I would like to.
Yes, sir.
Third one.
Sir has not finished.
Yes, sir. Yes,
One more. Just one more, sir.
Yes,
sir.
Which is operative, but incidentally, if you are doing TAH only, conserving the ovary, you may consider ovarian elevation stitch, so that any mass appearing in the ovary becomes easily palpable to the woman. It comes in right iliac fossa. So all that you have to do is put a stitch, just like, Williams, plication of round ligament. Plicate the round ligament, immediately the ovary comes up. So if she gets a lump, she need not wait for 1 or 2 years at a PV or something to know. She will immediately, thin woman will know even when it is 5 centimeter, and fat woman at least a little more bigger. So this is high fixation of ovary during hysterectomy, conserving the ovaries. And the third thing is, it's known now all over the world that cancer is a disease of immune deficiency. So AIDS patients have high cancer, and those who have congenital immune deficiency also have high cancer rate anywhere in the body. Now, the CA ovary patient has been found to be insufficient. So any patient with some risk factor should have immune profile done once a year. It does not cost a lot of money, about 850 rupees from all the big labs. And if they are immune deficient, they should be given immunotherapy, means normal, so that if the immunity improves, that it will not only prevent CA ovary or CA anywhere in the body, and also the other infection and everything. So I have these 4 suggestions for your consideration. Thank you.
Very nice. Very nice. Yes, sir. Thank you so very much. Dr. Bhagya Lakshmi, we'd like a few inputs from you.
I think after the brilliant deliberation by Madam and very excellent inputs by Alok sir, so I'll be only showing a candle to the sun. So only a few things I can just add is that sir has so nicely told, and Madam has also mentioned that lifestyle change is so important. And about PCO, I think it's a hyperestrogenic environment in the ovary. So on the long run, so there is a chance of some estrogen dependent tumors like granulosa cell tumor and all those things can happen. And as sir has told, incessant ovulation. So that was initially thought as a very, very important cause, because each time there is a breach in the epithelium on the ovary, and when it heals, sometimes it would heal nicely, otherwise sometimes the cells would go astray and then form some type of tumor. And the third thing, but now there is a little change in that, because we are thinking about stick, that the ovarian cancers are all arising in the fimbrial end of the ovary of the tube and then implanting on the ovary, because we rarely see a tumor arising in the stroma of the ovary. It's most of the time it's on the epithelial surface, it's a epithelial cancer. So so whenever we are doing a tubectomy, so it's ideal to do at least a fimbrectomy, so that we prevent many of these high-grade ovarian cancers which are thought to arise from the fimbria. And when we are doing a hysterectomy, as sir has told, ovarian placation is very important, but we can do away with the fimbria also, so that the fimbria and the fallopian tube totally, and so abdominal hysterectomy with bilateral salpingectomy or a NDVH with bilateral salpingectomy. So that is very important. That will go a long way in preventing these cancers. And the third important thing is, when we are doing hysterectomies for benign conditions, please take a history for ovarian tumors in the families. So actually we don't take too much of history. So I think if there is a history and you are in a doubt whether to remove or not to remove the ovary, so if you take a history, I think that will again help you. And all my friends here are all are ultrasonologists. So kindly see the ovaries for yourself. And before, if there is little suspicion about that, don't meddle with the ovaries with laparoscope, because the first surgery is the best surgery, and capsule rupture and all those things actually makes the life of the patient hell. So I think that's a little message that I wanted to share with all of you. Thank you so much.
Fantastic.
Am I audible? I also want to say something. Excuse me.
Yes.
It has been seen that breastfeeding also prevents ovarian cancer. So we should encourage breastfeeding as much as possible.
Yes. By 8%, breastfeeding is very much protective factor for everything. Yes. Like in South, what is the low middle income country, what the world calls us. But actually in what is concerned, that we may be like, we have not that accessibility to treatment of the cancer, because mortality and morbidity is much high in our setup. So we must like retain what is there in already in our system. So breastfeeding, completing childbearing at right age. Like every childbirth also reduce the risk of ovarian cancer by 6%. So there is also that the today women don't want to bear children and don't want to cook. So many things are there, and we are having packaged food. So these are the things actually that Lucky Bhagya Lakshmi, and we have so many leaders here, Dr. Suman Sinha, future leader, everything, everybody, I think everybody is a leader and professional in ourselves, and somehow we must retain that no packaged food, no fat, preferably less non-vegetarian diet, and the right time breastfeeding and right number of children by every woman. So, and the environmental toxication we can't help, but and opportunistic what Sir and Bhagya Lakshmi says, actually the opportunistic salpingectomy is a way of something to prevent the epithelial ovarian cancer, which have a much worse prognosis. But for endometrial and clear cell, which is a little higher in our country, again I will say that like follow every adnexal mass with na to usko daraiye, neither you frighten up, but make a standard protocol that how many like how frequent it is, 6-week follow-up, 3-month follow-up, or 6-month follow-up. So this is important thing. And thank you, very innovative ideas about from Dr. Alok Devdas also.
Fantastic. This
Thank
was
you, Sadhna.
okay.
Can I just say just one Bolu?
Yes,
Sure,
yes,
ma'am.
sir.
Sure, sure.
Yes, yes.
Excellent talk and excellent suggestions by everybody. I just wanted to appeal to everybody, especially this happens when the people are doing a lot of laparoscopic surgery. They tend to remove healthy looking ovaries. अगर 48 age की उम्र में किसी का hysterectomy हुआ, what is the need to remove the ovary? The ovary is still going to suffice. The patient is not yet menopausal. Till 55 years, till 60 years, is going to get some hormones. If there is no family history of ovarian cancer, they're looking absolutely healthy. Please don't unnecessarily remove ovaries because you have to remove 120 pairs of ovaries to save one. So unnecessary removal should be avoided. छोटा सा cyst दिख रहा है निकालो ये. So if they're looking healthy, if everything looks fine on the ultrasound and on the visual thing, please don't remove ovaries. जिसका castration होता है, the woman goes through hell. And menopausal hormonal therapy हम कितना भी बोले लेते नहीं है. So just be very careful, be very judicious before you decide to remove the ovaries. Thank you.
Yes, I think that's more with surgeons. I think gynecologists are a little kind with the ovaries, but a lot of surgeons are doing lap surgery, and so they'll end up removing really everything. And I think removing ovaries even at 70, I'll tell you, it really also has some health hazards.
And they may leave femoral end of fallopian tube as well. they may remove ovary, but they will leave the
tube. Yes, yes. Nivedita has asked a question. Nivedita, why don't you go ahead?
Sorry, I was muted. Ma'am, just now Professor Sujitra Bandit ma'am said about preserving the ovaries, and as Dr. Bhagyalakshmi said, all of us are doing the same because all of us are very concerned about the effects of estrogen. But I've seen a lot of cases of simple ovarian cysts occurring after preservation of ovaries for just doing hysterectomies. So is there some reason? I mean, because they don't have a target organ and hence the ovaries have these hormonal problems and tend to have unruptured follicles and cysts.
And how could we have prevented it?
Yeah.
Both.
I will just say, Nivedita, that is thing we have after hysterectomy, we have a 2 or 3 small cysts, which is not going to increase. Like it is not increasing in size, it is not painful, then we can, first of all, we must reassure because we are having a lot of patients who comes with the cyst and they are always afraid. Secondly, what we see, because we are not doing self-injectomy, we see a hydrosalpinx, that is adhesion surrounding fluid and the peritubal adhesion, what we get in the like PID. So it remains cyst, but my takeaway is that what we should not be frightened the patient, because patient is very much frightened that we have done hysterectomy. If it is not increasing, if it is there, if it is not causing, sometimes the antibiotic course do like quite well for the PID. Just follow them, and it is not a close follow-up. It is like once in a year or once in a 6 months. So reassurance is the way if we have preserved. And again, it is 2 or 3 causes, that it is adhesion, it is a adnexal like a hydrosalpinx like picture, and we have the surrounding like adhesion. So it is always adhered. Sometimes it causes dyspareunia, and to me it is usually doxycycline 10 or 14 days course does better. But to reopen is not the way. This is, I am concerned that please don't frighten the patient and go for again one surgery. So this is
agreed. Okay, I think with this I'll now request Dr. Maushmi to proceed with the panel discussion.
Yeah. Thank you, Madam, Dr. Sadhna Gupta, for such an excellent talk, and the patrons. Everyone has given their views. It was an excellent discussion. And thank you, chairpersons, Dr. Pratibha Rai Madam and Dr. Suman Sinha Madam, for chairing this session. So moving on to the second session, HPV positive, what next? We have the moderator. Next, Dr. Bhagyalakshmi Nayak, Chairperson of Oncology Committee 2019. Next slide, please. She is FICOG and PhD. I think her PhD, Madam, your PhD subject was, I think, on HPV. Yes. And she's an associate professor in Acharya Harihar Cancer Institute, Cuttack. She's co-chair Oncology Committee, CEFOC, Governing Council member of ICOG, Chairperson Oncology Committee, FOXY, 2018-20, Vice President of AOGI in India, Joint Secretary.
I think it's enough, Maushami. Please go ahead.
Yes, madam, a very humble person, full of life. We have 8 panelists, 2 each from Bokaro, Ranchi, Jamshedpur, and Dhanbad. So introducing, next slide, please. Dr. Nivedita Datta. We already had her in the discussions. She's a senior gynecologist of Bokaro, ex-president of Bokaro Obs-Gynae Society, organizer of various conferences.
Maushami, just let go the CVs. Just read out the names. Let's not waste.
We should not waste time.
Yeah. Next slide, please. We have Dr. Rupam Singh from Bokaro. She is the HOD of Bokaro General Hospital. Next slide, please. Dr. Meenakshi Kumari from Ranchi. She's a young gynecologist working in FOXY MTP committee member now. Next slide, please. Dr. Anuvi from Ranchi Society. Next slide, please. We have Dr. Sarita Kumari from Jamshedpur. She is the present Vice President of Jamshedpur Gynae Society working in Tata Main Hospital. Next slide, please. We have Dr. Ruchita Sinha. She's a specialist in Tata Main Hospital and she's the past secretary of JOGS. Next slide. We have Dr. Abhijit Mandal. He's from Dhanbad Society working in Tata Central Hospital, Jamadoba. Next slide. And we have Dr. Samir Hazra. He might be joining us. Next slide, please. Yeah. So, Bhagya madam, over to you for the panel.
Yes. So, Maushami, thank you so much for this opportunity and especially sharing the dais with elite people like Dr. Sadhana madam, Suchitra Pandit, Dr. Alok. I think it's really a privilege and thank you so much for this opportunity. So, we will be discussing about HPV positive. So, I think, hope my slide is visible.
Yes.
Yes, ma'am. It's visible. And it is always a privilege to have you. We always don't hesitate to talk to you and call you anytime, any moment.
Thank you so much. So I think with cervical cancer incidence rising, in our country too, we have the records in the Globocan 2020 that the cervical cancer incidence is rising. And all over the world, it has now again become a huge concern. And the world has realized that this cervical cancer is a totally preventable disease and has really no business to be here. So I think with this, the WHO new guidelines in 2021 have shifted their model of screening from something very non-specific like cytology and VIA to a more specific test of HPV. So I think in the near future, we will have more and more HPV tests and we really have to know how to interpret the results. So I think cervical cancer in India especially is a real huge problem, and I'm really happy to hear from Sadhana madam that they are getting less and less cases, but all over I think India is a diverse country, so the bringing all the data together, the cervical cancer is still a problem, and 25% of the global deaths do occur in India. So this is the Globocan 2020 data which has shown that there has been an increase in incidence and death. Cervical cancer incidence is 96,000, around 1 lakh per year, and cervix deaths are again around, the deaths are around 1 lakh and the incidence is around 1,23,000. So, and unfortunately, the problem is that most of them again come in advanced stages when we are really not able to do much for them. So today, remembering Professor Harald zur Hausen, who was the main person who discovered that HPV is the cause of cervical cancer and was awarded the Nobel Prize for his work for establishing a causal link between HPV and cervical cancer in 2008. So this set a new paradigm ahead, and this HPV testing gives more granularity in the treatment protocols as against our very age-old cytology, which really needs a continuous call and recall method of doing the test, and again visual inspection with acetic acid, which is again a very, very non-specific test. So I think HPV DNA tests are the coming in a huge way for the prevention of cervical cancer, and it means a high risk HPV DNA test, which is nucleic acid amplification test, which may be qualitative or quantitative, though the specificity is little less than cytology, because as you all know that HPV test positivity does not mean cervical cancer. It's only the presence of the virus. So this virus may be thrown out by the body even by a good immunity system. So it's not very, very specific, but it is a very sensitive test. So for areas in which cervical cancer is very prevalent, HPV test is also a very good test. And if you need to do something more specific, we can do the E6 and E7 viral protein, which is more specific. And to overcome this less specificity, it's ideal to do it only after 30 years, because in younger population, the rates of HPV DNA are very high, and which does not most of the time in progress to cancer. So we have the new WHO guideline just released in July 2021, in which we have that HPV test should be done for all around 30 years of age in the general population and 25 years in HIV positive women. And this again has to be followed up by some screen and treat approach with visual inspection acetic acid and HPV DNA as the primary screening test, followed by treatment. And this can have a screen, triage and treatment approach also. So I think we have, WHO has many guidelines, but out of that HPV DNA testing is the number one. So I think Dr. Samir is not there with us. So anyone else? Nivedita? Hello.
Okay.
Yeah, I think you are the opening batsman, so we go ahead with you. So what are the methods of HPV testing that are available world over, and how do we go about that?
Well, we have mainly two methods of HPV testing, and one was the blot method, the routine blot method. Ma'am, could I go to the slide? Next slide, please.
Yes.
Yeah.
Yes.
So we could have the hybridization assay and the simple amplification assays, and I think the southern blot technique. But honestly speaking, as I mentioned to Dr. Bhagyalakshmi, we are not an expert in the different methods of HPV testing. So if she could elaborate about this, it would be very beneficial for us. And what is the difference between the two, and what exactly are we doing right now?
Yes, I think Nivedita, we have learned a lot from the coronavirus testings.
Yes.
So I think those are basically, it's on the amplification of the human papilloma, the DNA of the viruses. So one is a nucleic acid hybridization assay, one is an amplification assay. There are actually two methods, but both of the methods are identifying the DNA. We incorporate the DNA, collect the DNA from the specimen. Either sometimes we are still doing it on the cervical smears, but sometimes urine collections is now again going to be the test. So the DNA is collected. So it is separated from the cells, isolated. Some primers are added to it so that we identify them, and the numbers are increased, and then they are tested so that we identify them. So one is a hybridization, one is the amplification. Both the ways we are increasing their numbers so that we can identify them. And so, and these are some of the tests which are available. But then when we are advising for some HPV testing, because, and be aware all my friends, that this is the now being marketed very, very rampantly by many pathological units, who pathological companies who are coming up. But please check whether the method that they are marketing is FDA approved or not. So there are many methods which are available, but I think out of these, the Cobas 4800, Aptima, Digin hybrid capture 2, and BD Onclarity, these are the four which are FDA approved. But there could be many more methods, but I think we have to choose which is FDA approved, so that we do not land, because there could be sometimes some erroneous results, HPV test positive, so that the reports come HPV test positive, and you are nowhere what is a positive, whether it's a high risk positive or low risk positive or what. So I think you should know which test to choose. So Dr. Rupam, are you there?
Yes, she's there.
Yes. Good evening, Dr. Rupam.
Acha, she's there.
I saw her name in the
Nivedita, just check.
Am I audible?
Yes, Rupam is audible.
Yeah.
Yes.
Good evening, all. I want to add one more test in this. This is there are two sets of tests. One is DNA test for HPV, and one set is RNA test.
RNA test, yes.
RNA test. The RNA test tests for protein, oncoprotein E6 and E7.
Yes.
That is also FDA approved, I think.
Yes.
And it is
You mentioned about that.
more
E6 and
specific
E7,
and
more
sensitive.
specific. Yes.
Yeah.
Thank you so much, Dr. Rupam. Yes.
Okay.
So if your patient comes to you with a report that she has HPV positive, so they look up the Google and they see that HPV positive means cancer, and then she comes to you. So what is the significance? How do you interpret the result, and how do you counsel her?
Recently, I had one case, so I read a lot about it. So HPV positive test. To understand this, I will make a brief review of pathogenesis of cervical cancer and how does HPV virus causes.
Dr. Rupam, can we have your video on, please, so that it will be more?
Yeah, it is on. It is on. Okay.
Okay, we can't see you. Yeah. Very nice. Yes.
Yeah. Okay. So I will make a brief review of pathogenesis of cervical cancer. How does HPV causes this thing, cervical cancer? The story starts with the microabrasion in the cervical epithelium at the transitional zone. And what happens, the HPV virus goes into and resides into the basal cells of the cervical epithelium. Here it acts as stays as a episome, and that is the DNA material not incorporated in the host genome, host chromosome, but it stays freely in the nuclear plasma. And here the story starts. It stays with the patient, the host.
It takes control of the cell then.
Yeah. And now it stays in the host cell, and it with the proliferation of the cervical cells, it goes, but it does not disturb the proliferation process of the cervical cells and the architectural process of the cervical cells. It stays there, and with the host immunity, it goes off. The infection goes off. But in most cases, infection goes off. But in some cases, it persists in the basal cell, and it persists for a long time. And when the host immunity is low, then what it does, it incorporates with the host genome. Then the problem arises, and it expresses E6 and E7 oncogenes, and then the proliferation of the cell and the architectural structure of the whole cell thickness goes away. So there is an expression of the clinical appearance of the cervical cancer. This is the natural history. This is the pathogenesis of the cervical cancer. So if the HPV is positive, it means it doesn't. It means it is infection is there. It may be there. The virus is also persistent, or it is active. It may cause precancerous conditions. So all three stages of the process it can do. So only HPV positive doesn't mean that she will have cervical cancer in future. Most of the cases it passes off by the body immunity. In some cases it persists, and in few cases when the host immunity is low, then it takes control of the cell differentiation, and cervical cancer or precancerous lesion. So HPV positive this time we know that HPV positive, but we don't know whether it will go off, or it will stay, or it will cause precancerous lesion. So for that we have to go some few tests. So these are that we have to exclude the precancerous lesion by visual inspection with help of acetic acid or cytology, or by genotyping of the high risk HPV vaccine. So these are the things we have to try the things, and then we have to go forward.
Yes.
So I think this will be discussed in the later by those
So I think counseling of the Rupam, thank you so much, Dr. Rupam. So I think counseling of the patient is so important because women with HPV test positive report, they really come and request you for a hysterectomy. So they have Googled and they think a HPV test means cancer. So I think that's where our role comes, that HPV positive does not mean cancer. So we have to explain it to the patient. And so if there is, then we need to really interpret the report properly. If sometimes the HPV test vendor gives a report of with a direct genotype that 16 is positive or 18 is positive. So again, we should keep in our mind which are the conditions in which HPV is going to persist, especially in the elderly women. If 16, 18 is positive, and if she also has a smoker, immunocompromised, or there is some kind of bacterial vaginosis. So these are all cofactors in which there is a chance of HPV persisting. So in those cases, I think WHO also has a guideline that you can directly go and treat the cervix with even if without any triaging with VIA even. So HPV positive, you can directly do ablation of the cervix. But then in Indian context, I think visual inspection is very, very important, so that we need to look at the cervix once because a positive test, if you are leaving it to just like that and not looking at the cervix, you may miss out some kind of cancer also. So I think it's so important that we look at the cervix with a positive report. And if it is negative, yes.
One more thing is that in our country, we don't have screening program. So we don't know since
so
how
this
long
is
she's
all
having
opportunistic. Yes, as of now, it's all
since
opportunistic.
how long she's having this infection.
Yes.
And maybe from long time she's having this infection, that high risk 16 and 18. So it may cause.
And Dr. Rupam, and it's also a social problem. They think it has come from the husband. So they think that the husband is not like very having some other relation or something. So that again sometimes lurks in the minds of the woman. So that again we have to clear it up. That
this is a common cell. It is a common, very common infection on a human skin and
because so these are the small things which we have to look, and they think it's a real taboo to have a HPV infection. So thank you so much. So Dr. Anubi, you are there?
Yes, ma'am. Good evening, ma'am.
Yes, very good evening. So I think we have the HPV vaccine, which is being introduced. I think though it's still sporadic, we do not have any government-run programs except in Sikkim. So we are expecting that with the introduction of HPV vaccine, especially the nonavalent types, that the HPV testing which we are getting and the reports that we are getting, there will be a little difference, is it?
Yes, no, ma'am. Actually, the thing is that in the HPV vaccinated women, according to a recent study in 2020, it has been found that the non-vaccine HPV virus types were prevalent.
Yes.
So in a way, the women who were vaccinated for HPV, mainly the Cervarix, which is against HPV 16 and 18, and quadrivalent, which is Gardasil, which is against 6, 11, 16, 18. Those subtypes were not found in the HPV vaccinated women. So in a way, it protects against the most common types of HPV viruses which infect the cervical area.
However, there are other high-risk types. So I think the new HPV tests have to take into account the other viruses which are not included in the vaccine. So in the post-vaccine population, we have to include other viruses also, because now the tests that are available are mostly for the 14 viruses. That's 16, 18 and 12 other high-risk types. So I think we have to look at the other high-risk types which are not covered by the vaccine. So I think this is the study which you were referring to, in which it has been shown that human papilloma virus types in cervical dysplasia has shown that vaccine targeted HPV types were rare among both CIN cases and their matched controls, and no woman had HPV 6 or 11, and the other CIN lesions were associated with non-vaccine HPV types 31, 33 and so on. So I think there needs to be a little, there to be some change in the structure of the HPV testing that we will be ordering next. So Dr. Meenakshi? Hello, Dr. Meenakshi?
Good evening, ma'am.
Yeah, very good evening, Meenakshi.
Can we see her? Yeah.
Yeah. So I think many times we get a report of HPV positive.
So it's just a HPV positive. So would you advise doing a genotyping to know whether it's 16, 18, 45, 58 or whatever? Is it required routinely? Do you practice sometimes or is it not necessary? What is your viewpoint on this?
Thank you, ma'am, and all the respected seniors and dear friends. And as ma'am, HPV is the papillomavirus is associated with almost all cervical cancer, but plainly HPV is not associated with cancer because there are so much varieties of HPV. High risk HPV have also different rate of oncogenicity, like HPV 16, which is associated with 61% of cases, 18 is associated with 10%, 45 is with 6%, and so on. So if we know which type of HPV is there, we can decide the further management in a better way.
Yes.
The
So
current
yes. So if you have the facility to do a genotyping, I think you can take advantage of that, because it's so important to know, because HPV we have to understand are of 100 types. So HPV positive, we have to communicate with the laboratory what HPV positive result means, whether it's the high risk type or the low risk type. And if the high risk type, again in the high risk type also we have some genomes, some HPV type like the 16, 18, etc., which have a very great potential to become persistent and then progress to cervical cancer. So I think if the facilities are available, genotyping can be done, because the diagnosis of HPV infection for cervical cancer screening plus clearance of HPV infection eradicating the related cervical lesions. So I think HPV genotyping for co-testing, this can also be like a co-testing for the HPV positivity. HPV genotyping can be used for triage, HPV genotyping for primary cancer screening, and home-based HPV genotyping. So all this can be done, but then if it is available, I think we should always take help of doing the genotyping. So the current recommendation is to perform either a follow-up test 12 months later or genotyping of HPV 16 and 18. If the genotyping of HPV 16 and 18 is negative, you can go ahead, do co-testing after 12 months. But if it is positive, you should go for an immediate colposcopy. So a recent data reported type-specific HPV genotyping improves the prediction of CIN recurrence as compared to HPV testing alone. And patients positive for HPV 16-18 would undergo colposcopy, while patients infected with any 12 other high-risk HPV types would be tested by reflex cytology. And recent findings suggest that the use of HPV genotyping testing as a primary screening tool will increase and thus play a more important role in cervical cancer prevention. So if we can do the 16-18, I think we'll avoid so many unnecessary colposcopies. So if there is 16-18, then we do the colposcopy, and the rest others we can just call them after for a follow-up.
So ma'am, if it is negative for 16 and 18, then interval between investigation can be safely extended.
Yes, exactly. Thank you so much. So Dr. Ruchita?
Yes, madam.
Yeah. So Ruchita, I think we have discussed something, but then please add again, how do you counsel a woman with a positive HPV test report?
Thank you, madam, for the opportunity given. So, so why counseling is so important? First of all, it helps to reduce patients' anxiety and fear, obvious fear associated. It satisfies patient information needs, which is a right of patient, of course. And it helps in follow-up of these patients. If they understand well that follow-up is so much required, then this is so much required for the treatment, for better treatment of the patient. So there should be a pre-screening counseling, and the counseling about the screening result, and pre and post-treatment counseling. And we should counsel these patients in simple language, should be empathetic of their pain and the anxiety, and give a detailed description of the treatment options. So now we have this patient which is HPV positive. And so we should make sure that she should understand that there are many HPV subtypes, and they are generally present in the body, and usually they don't do any harm, and they clear by itself, usually by 1 or 2 years. But if it persists, and in the presence of predisposing factors such as OCP use, multiple sex partners, multiple births, smoking, and co-infection with HIV, it can cause pre-invasive lesions. And thus we should always counsel these patients about the protective methods like use of condoms and availabilities of various vaccinations programs available.
and which should be usually started at the age of 11 to 12 years of age. Now,
That's
we
the
have
best
this
time, actually. Best time when a woman comes to you with a HPV report, that's the best time you counsel them for the vaccination.
Yeah, we should also tell, madam, that it is we can give till 25 years of age. Usually, patients are like they are anxious now. It is effective or not? What should we do? So it is the best time. Yeah. So now we have this HPV positive report, and we should. The most important part is giving her all the treatment options, which entirely basically depends upon the resources available. Now, if you are working in a low resource settings, the best option is to visual inspection through HTK. If positive, go for colposcopy biopsy. If negative, nothing to worry about. We have to repeat HPV testing after 1 year. If we have facilities for co-testing with cytology, the best. If normal, repeat HPV testing after 1 year. If ascus or greater than ascus, colposcopy and biopsy. And the best part, as always already discussed, if we have the genotyping available, if it has come out to be positive for 16-18, colposcopy biopsy, and otherwise repeat HPV testing for 1 year. And so the importance of proper counseling goes a long way in treatment of such patients. And so important, especially in India, where there is less, patients are not aware. We get patients from far off places where we can't impart the information. So the importance of counseling.
Yeah, Ruchita, thank you very much for explaining so elaborately about, because counseling, this is the most important part that where all busy gynecologists lack. But so in case you are not able to give time for counseling, I think you should always take the help of your paramedics who can really sit with your patients and discuss with them that this would happen. Otherwise, they would land up with some hysterectomy. If you are not doing it, then some other surgeon will go and do this hysterectomy. So that's not an ideal situation to do hysterectomy for HPV positive. And number 2 is about the vaccine. So they can also tell them about the vaccine. And the one thing which I think we have to remind everyone, that if she has done a HPV test and the HPV test is negative, and if you have the HPV negative test report this time, and if you are calling her back after 5 years, if the initial has been with self-sampling, I think self-sampling with HPV test is also coming up in a big way. So that's a better option, because you don't call the patient to your clinic always. She can collect it, do the test, and share the information with you. And if it is positive, she comes to you. So in a screening setting, that's a very good thing. But if this time she is negative and this time it has been self-collection, the next time after 5 or 10 years, when you call the patient for HPV testing again, please remember to do it yourself or a provider collection, because it has been seen that some maybe not a very high percentage, very less percentage, but still there is some kind of missing out when we are doing it with self-sampling. So that is one important point that we should remember. So I think we have discussed everything. So if you get HPV positive report, you can follow them up with a cytology, with a genotyping, or with a VIA. So VIA actually costs you nothing except for a very good light source. So you need to prepare freshly prepared acetic acid, apply it on the cervix, wait for a minute and see if that's positive, take a biopsy. Or the best thing is if it's a VIA positive, if we are not available, your biopsy facility is not available, please you can do a direct cryo or a thermal ablation. So that's also important. So cryo is a little cumbersome, takes time, but thermal ablation takes only 40 seconds. It's a handheld battery operated machine which you just have to touch on the cervix for maybe 20-30 seconds, and it just forms a whitish protein on the cervix, just like a boiling of the egg. And it's almost painless, and the patient can go home immediately, and the post-op complications are very, very minimal. And the advice is just that you have to tell them just for abstinence for a month or so, and then you can call them back again after a year to see the HPV test alone. So thank you again, Ruchita, for explaining so nicely about counseling. So again, Dr. Sarita.
Good evening, ma'am. Am I audible?
Yes, very much audible. So just explain that what is triaging and why it is necessary. If you get a HPV positive report, why do we need to triage? What is triaging and why it is necessary?
Well, triaging is an additional step interposed between screening and diagnosis to further stratify the individuals with positive primary screening test result according to the according to the risk for the disease state. And triaging is required when the primary screening test lack specificity in poor resource setting situations, and if the diagnostic procedure is expensive. It has added advantage of reducing over treatment, and it also reduces the overall management cost by reducing the number of diagnostic procedure without sacrificing the sensitivity of the detection of the disease. And triaging also reduces the anxiety and inconvenience to the patient. But if the initial screening test is highly specific, triaging test is positive for vast majority of cases, and or if triage test results in decrement of the sensitivity, then its utility is questionable.
Yes. So, would you like to comment on this slide, Sarita?
Yes, ma'am. For general screening, we can do cytology by using pap smear or liquid-based cytology, or we can do HPV DNA testing, or by visual inspection of cervix by applying acetic acid or leukocidin. Then, if the report is positive, then if any one of these screen test report is positive, then we can do triaging by repeating the cytology or HPV DNA testing or visual inspection using colposcopy for screening process. If the report is negative, then we can go for return to routine screening, and if the report is positive, then diagnosis can be done and risk clarification should be done. If it is in high risk cancer group, then we can treat the patient with LEAP or cryotherapy or cold knife conization. And if it falls into the low cancer risk group, then we can do follow-up beyond routine screening by doing HPV DNA testing or cytology or colposcopy.
Yes, I think the whole essence of doing a triaging is that we reduce the over treatment of many patients, because the HPV positivity report does not mean cancer. So if we can add something else to it, like a cytology, genotyping or VIA, so that's called a triaging. So that will reduce the number of women that will really need treatment. So that is the issue of triaging. So Dr. Abhijit?
Yes, good evening, ma'am.
Yeah, very good evening, Abhijit. So, what triaging test would you recommend for an HPV positive woman? If she has come to you, what is the triaging test that you will recommend and why?
Good evening, everybody, my respected seniors and my colleagues. Thank you for this opportunity. The main question arises for primary screening method is sensitivity and specificity. The HPV testing is itself is very sensitive, but it lacks its specificity. So that means HPV testing will be positive even when there is no CIN. And HPV is a test of infection, not necessarily CIN. So it requires triaging with other tests like visual inspection with acetic acid, cytology, HPV genotyping to make it more specific, that will help in further treatment. So at first, HPV screening done, and if patient came positive, then the accepted method, we can go for colposcopy, but the preferred method is to triage with other tests like already stated VIA, cytology, and genotyping. If these tests comes negative, then we will go for yearly HPV testing and then 5 yearly. If these triage tests are became positive, then we must have to do colposcopy and if requires biopsy also.
Yes, I think we all have to learn also colposcopy. So colposcopy is not a very difficult thing. So I think when that's a great armamentarium in the management of HPV positives. And but still, I think we should not think that if I don't have a colposcopy, I cannot manage these cases, because WHO states that even if you have a HPV positive report, and even if you do not have facility for a cytology or genotyping or even VIA, you can directly ablate the cervix. So ablation can be done by cryo or thermal ablation. So but the WHO guidelines are thermal ablation. So, but then in huge settings like in India especially, it's ideal to do a visual inspection so that you can see the cervix once, because we may be missing out cancer. So that's the biggest important thing, that we should not miss out cancer in a HPV positive woman. So we have to look at the cervix, and that should be done with a good light, and apply freshly prepared acetic acid. And if possible, it's always better that if it is a very suspicious looking cervix, to take a biopsy so that you have something to back on even after you are ablating the cervix. So again, this is a guideline, and we also have very good guidelines from our Foxy GCPR, which was formulated, of course, in 2018. This is a little old, but then it's almost in sync with the WHO guidelines, because we have a resource-based management. So if you are working in a low resource setting, you have something to do. In middle resource setting and higher resource setting, you also have something to do. So this is again WHO and Foxy guidelines also. So I think Dr. Nivedita.
Yeah.
So what is the role of screen and treat approach for HPV positive women?
See, the major problem which we have in our country is a lack of follow-up. And one, ours is a resource poor country. Then two is that we cannot guarantee that the woman will come to us for a follow-up and for all the procedures that we are outlining for her. So then there's this concept of screen and treat, rather than like right now, we have been hearing about screen, triage, and treat. This is what we have been hearing, and it is, of course, the most, I would say it is the best thing, because then we're not over treating. But this is something which has been recommended because of poor follow-ups, and we may not get the woman. So if we can screen and we see a VR positive or even VLI positive, and we immediately do if you have a facility for cryo, then you do a cryotherapy or a thermal ablation, whichever you have in your setting. It is recommended, however, that if the disease is more severe, if you feel that the mass is bigger, then thermal ablation is preferred to cryo. So this is one thing. Now, but here I would also like to point out that although we say VI is very simple, VI is very easy to do, and the government has been training a lot of ANMs about VIA, but it is also, one has to know how to pick it up. So some kind of training should be given to the people who are doing VIA, and that is also very important. You just can't let them go off and say, okay, do VIA, and then we'll be facing with a huge number of people who are VIA positive. And then secondly is that a woman should come forward also, because when you say screening, the very word screen means it should be universally done, which is something what we are doing is actually we're just doing a high risk thing in our country. But screening for all is supposed to be the one which should be recommended. So we have to go out, we have to increase awareness among the general population that they should come forward. So if it can be done in their settings, it would be much preferable rather than doing it in your, say, we should do it in our OPDs. I'm not saying we cannot do a screening in OPDs, but we should also be doing it in outer settings so that we can pick up, and if they can be treated then and there, it saves them working days lost. So there are no working days lost for them also.
Yes, I think we should have some kind of wellness centers. I think the government is also working a lot on this, because patients don't like to come to the hospital for this test, and especially not to cancer hospitals.
Absolutely.
So I think once she has some positive report, maybe then we can call her to some place for this. But until she has she continues to have a negative report, she is a simple woman. She is not a patient. So that has to be understood. So they really don't want. And all these preventive clinics have to be very appealing. Like I don't know, that they should feel like they should feel like coming. Like they should not
absolutely. It should not be like I'm going to a cancer hospital and have got cancer, because that is something very frightening for everybody.
Yes.
So the very word cancer itself is very frightening.
Yes. So, and I'll just tell you one practical problem that we are facing right now, that we had a pilot project of self-sampling with HPV, and so we sampled around 2,000 women. Out of that, around 100 women were positive. And the first 2 sets of 10 women came to our hospital. And then the experience, I think they shared with their friends who were also having some HPV report, then they stopped coming. So now we had to go to their nearby clinics, request them that please come and do the thermal ablation. So this is what happens. So they really don't like to come to the cancer hospital and take the taboo that they are harboring some kind of cancer.
Yeah, actually, denial is the first stage of any disease. No, so
yeah, and for all this, I think we need, I think Dr. Sadhana Gupta, we have leaders here who will also help us in creating some kind of modules and infrastructure for mobilizing, educating communities, meeting women schedules and needs, strengthening systems to track clients, appropriate training of healthcare providers, adequate number of trained providers, and coordination between outreach providers and service providers. So I think Foxy is a real could be a real game changer in all this. And Foxy and Government of India working hand in hand. So that's what our vision should be. And Dr. Sadhana is here to help us out. So what advice will you give to an HPV negative woman? So if a HPV negative woman has her report, it tells it's HPV negative. So what will be your advice to her?
HPV negative is a good thing. It is a good news to the woman. But at the same time, a word of caution should be there. It is for the present time, it is negative. But in the coming future, she can have this. So she should be kept in surveillance all through her life in our setup. But in Western countries, it is up to 65 years of the age till the previous negative report. But in our country, we don't have that screening system. So we have to keep the woman, I think, till lifelong. When they come to us with postmenopausal bleeding or something else like that, we should go for this. I think.
See, if it is combined with cytology and it's negative after 5 years, we should tell them to get it repeated.
No,
the
unfortunate not 5
problem,
years. It is 10 years.
But I think now though it has not come in the guidelines, but I think it can be extended up to 10 years.
10 years. Yeah,
it is 10 years. It is 10 years.
Yes.
Foxy GCPR hasn't still said 10 years, but yes, it is coming up.
Yes.
But
the Western guidelines are saying this is
10 years.
HRHPV for 2 negative, and that 4 testing 2 negative, and 3 cytology negative previous. Then we stop testing the surveillance.
So we tell them not to smoke and lifestyle changes, use of condoms, and of course, the screening guideline has to be followed. Okay. But then just a word of caution that in the recent past, we have had so many cervical cancers which are really HPV negative. So there have been so many theories about how we could get these cases of cervical cancer which were HPV negative. So that's a hit and run theory that the virus has come, cause the carcinogenesis, and then we cannot find. Many times there are false negatives, but the real true negative HPV negative, true negative cervical cancers have a bad prognosis as compared to the HPV positive cervical cancers, and they're especially their adenocarcinomas, and in the younger women, and nodal positivity is more. They are radio resistant, and the recurrence rates are also high. So this is yet another group. So when we have a HPV negative report, I think this is a word of caution. We have to tell the patient that she is fine. She can come back after 5 to 10 years. But in the in between, if she has some kind of symptoms like some white discharge, some some contact bleeding or some irregular bleeding, I think she should come back immediately. So HPV negative report, we should not sleep on it that everything is fine. So I think in Indian women, everything can happen. So we have to, this is also the time that we take a minute out of our busy schedules and tell her that if you have some symptoms, please go to your nearby gynecologist and visit her in spite of the HPV negative report. So I think we come to the end of the session today. So thank you very much, all my learned panelists. I hope our participants who have joined today must have learned something from this panel, and go back, and as Dr. Alok sir has told, that it should all culminate finally in improving the conditions of what service we give to our patients today. So thank you very much for this opportunity.
Thank you so much, madam.
If anybody who's joined in would like to share something.
Some special remarks from Sadhana madam.
Yes.
Yes.
First, take the remark from other, then I will express my views.
Anybody in the audience would like to share certain points? There are a lot of people logged in. So anybody from the audience besides the panelists?
Do we have any questions in the chat box about HPV? Then we can take them.
No, ma'am.
Okay. So
Keeping
we
an
can
eye.
take
Yes.
some points from Dr. Usha Madam, Alok Sir, and Sadhana Madam. Suchitra Madam is also there.
Well, it has really been lovely and enjoyable evening. And I'm really thankful to Dr. Ranjana, Dr. Maushmi for including me, and to see Dr. Bhagyalakshmi conducting such a nice panel discussion. And everybody seemed to be very knowledgeable, all the panelists. So it was also a great thing. Another thing is a good feeling that Jharkhand has formed this conference, the JAGO. We are awakening to our strength, and it's a great feeling. And now, in future, I visualize that more societies will be formed in Jharkhand in outreach areas, and our strength will increase, and we will come in central arena to show that we are positively helping women's health marker to reduce like maternal mortality, like cervical cancer, all these things. So I'm really happy to see this progress and development. And thank you, Jamshedpur Society, for organizing this.
Thank you, ma'am. Thank you so much.
I think Jharkhand has become really a happening state.
Yes, we should have that, this was my dream, actually, for long. So we are here.
Actually, participants cannot participate. They are muted, like only the...
Okay. But they can put it up in the chat box. They can't put it in the chat box.
I forgot, Nivedita, thank you very much. It is lovely to see your face.
Ma'am, it was your dream. Jago was basically your dream. Remember, you had said something like that when you go to Andaman.
Yeah, we remember. We talked.
Jago is a very befitting name also.
Bokaro Society for one time felicitating me, and I'm very thankful for that. And this is the time that I got Nivedita, just pass it on to your society, that I was very elated and happy about that. Thank you.
Yeah. We can make a slogan, Jai Ho Jago, something like that.
Yeah, Ranjana, you do it. You seem to have a good brainwave about this.
Yeah. Okay.
But it was a very nice.
Dr. Pratibha has come also.
Sadhana Madam, yes, a word from
Yeah,
Sadhana.
Pratibha
Yes.
also. Pratibha, thank you.
With a lovely discussion, Dr. Bhagya, very, very clear message, and I'm very happy about taking both scenario, that HPV positive and HPV negative both can develop CA cancer, because this is one issue actually. First of all, I will say right from beginning that HPV vaccination, what you say, we are Jago, we are like Foxian from every place. We can have a strong word that the HPV vaccination comes into the pediatric adolescent vaccination. The government is giving free vaccination for COVID. And you see in children vaccination, how many vaccines are added, and every person, every family take it, whether they can afford or not afford it. Many, many beyond the national immunization program. So issue is that we have to be very strong that the reproductive health and the women health is also important, and we must have a strong advocacy for it, that to make it a public health, and the like what we have this thing,
public health matter.
And that is the organization which give the low cost vaccine. That is also momentum, that they provide low cost vaccine to the low middle income countries. So as a professional organization, we must have, because girls are different and they need different. At the same time, at the adolescent age group, that adolescent sexuality is again it is a big issue, and now government has taken age of marriage to 21. You like it or not like, because today people don't want to talk about it, but I think again we should say what is in our Indian custom, that say no to premarital sex to whatever way possible. As an adolescent, what you say, even the Foxy expert, no, don't say anything to these girls. They are coming for 2 MTP or taking medical abortion. The professional will not say, then who will say? Who will say when we are talking about? So a little we should be not like going down to everything which is getting wild in our society. We must have some restraints actually. Social media हर जना adolescent और youth को बिल्कुल दूसरी दिशा पे ले जा रहा है, चाहे वो पैकेज फूड हो, चाहे वो बैड न्यूट्रिशन हो, चाहे वो वीडियो गेम्स का एडिक्शन हो, और चाहे sexuality. So this is, I think, as a future president, I am really focusing what is best in our country and how we should not bow to it. It is about this third thing, that whatever is the HPV report, my takeaway to all clinicians, always put per speculum examination in every reproductive age.
Exactly.
Because
yes.
HPV is a lab reporting. You might have the good lab or you might have a not that good lab. You might have that thing. So what you are seeing, it is in front of you. It is cervix, which is angry cervix, which is vascular cervix. You are having polyp or something, whatever. So please put speculum always in your clinical examination. Patient kabhi hesitate करती है, and usually the people are very busy. Once you are okay, अभी हर patient को मालूम है कि उनको ऐसे ही देखना है, so they will be fine. Because HPV, what is in like ultrasound screening, that is another, because it is a piece of paper, and what we are looking, it is just in the form of cervix. So always and ever we cannot get away with any report we can. I am so happy that you put HPV negative, and the cancer are more invasive and more rapid. And be careful about it, that there is a lot of issue in availability. We have VIA, we have VLIA, even most of us can have thermal ablation. It is just 2 to 2.5 like 40 seconds as a professional what we can do. But HPV testing also costs quite a bit. And we have to be very, very cautious that it is also that what works. So always put speculum, always take cytology, and see and treat option is fair enough in our country. And we cannot go away whether we are giving HPV vaccine or whether patient is HPV negative. We cannot get away with the regular checkup of the patient. So this is my takeaway, because a little concern कि HPV negative है तो patient बिल्कुल lost हो गई, कुछ नहीं, और HPV positive है तो hyper होके बहुत डॉक्टर भागे से वो कहते हैं कौन कैंसर रोज रोज कराएगा, so hysterectomy and all this thing, all positivity. मेरा एक बहुत important suggestion और है जो हम सब लोग ही मिलके करेंगे, when we have the insurance LIC और एनी लाइफ इंश्योरेंस, हम लोग डायबिटीज का चेक करते हैं, उसमें मैंडेटरी है, ECG इज मैंडेटरी, सो दैट दे असेस द थिंग. We will make ensure that the pap smear is also mandatory. So people will be knowing that this is a positive health and it is a recommended all for every woman, irrespective of marital status, irrespective of anything. Every person is having some LIC today in today's world. So this is 2 or 3 point HPV vaccination advocacy. Adolescent good health, never fear ki na multiple relation, okay, it is all, you know. आप USA को हम लोग करते हैं, लेकिन उनके यहाँ worst like scenario hai, still they are not able to prevent teenage pregnancy, and they are working. I see ki like don't do sex before marriage. They are working on it because they are fed up. No program
Time
is
has
working.
changed. Time has changed.
We have to revert and always put speculum. Never up. ये it is a high expert thing कि आपने HPV report देखा और सब clinician भी मस्त है और patient भी मस्त है, and she is coming with many problems. So we remain clinician and invest in equipment, colposcopy. अभी हम लोग करोड़ों रुपए का एंडोस्कोपी ले लेंगे, IVF लैब में फालतू के गजट लगवाएंगे, एयर क्लीनर, बट विच इज ए पब्लिक हेल्थ प्रॉब्लम. वी आर नॉट इन्वेस्टिंग इन सिंपल कॉल्पोस्कोप, सिंपल थर्मो एब्लेशन, बिकॉज हम लोगों ने इसको ग्लैमरलेस बना दिया है, ये हम लोगों के धक्के खाने वालों का काम है, और वो कुछ लाइक इट इज ए समथिंग ग्लैमर इन इट. आई थिंक एवरी साइंस हैज गॉट इट्स ओन glamour, own in depth and own pride. हम सब, every obstetrician and gynecologist, we must be proud of what we are doing. So because our mindset also has to be changed. Where to put money? It is in these instruments where we should put money. So thank you very much. I may be a little off the way, but I think that I should be heart to heart. There is nothing, whatever you always, we should be open to all suggestion, all opinions, and that is the way I had to go further. So
Madam, one suggestion to our future president. Madam, the vaccine actually is a little costly now, but if we can navigate through Gavi, it's only $5. So I think that should be taken up as a priority.
Yes, Gavi, that's why I said it is alliance which is giving low cost vaccine. और अभी तो India vaccine में सबसे top पे आने वाला है. Like we should be very proud of it that India is also in one of the top countries in vaccine research.
Government should make it available, madam. Like COVID.
Yeah, exactly. The price is so high.
COVID was available.
Only in Sikkim, madam, it's 100% coverage. So I think other states should take it up as a model, and I think government of India should take that model and carry it forward.
Where it is 100%?
Madam, Sikkim.
Sikkim, it is 100%.
Yeah.
100% fantastic.
And Bhutan has done, Vijay Bhagat, Bhutan has done 100% vaccination.
Even Madam Sri Lanka also. All our neighboring countries have. Actually, India is a huge.
I think this should be pushed.
We have to have advocacy because we need to have advocacy for it. Actually, जितने भी changes हुए, it is because of professional bodies advocacy कि हम लोग इसमें करते नहीं. It is needed. Even folic acid fortification program, it was pressure of health organization.
We should go to the government and get the
and
government
it is possible. It is possible.
Yes.
Yeah.
Yes. Thank you, Dr. Bhagyalakshmi, for this fantastic panel discussion. I saw some questions in the chat box. Can you just round up the answers? Just like one, something you want to just convey to the delegates? I just saw.
Is there any question?
Yes, there is one question from me.
Yes, ma'am. Yes, ma'am.
In guidelines, there is...
Dr. Abhijit, yes. Oh, sorry, ma'am is speaking. Yes.
In guidelines, there is that HPV test is positive or negative. There is likelihood of cervical cancer. So why in guideline it says that if it is HPV is negative, you do again test in 5 years' time?
Yes, madam. But I'll just answer that question because as of now.
Question is to you.
Yes, madam. Yes, madam. Thank you so much for this very interesting question. Because as we understand that if we have to do some kind of screening because cervical cancer is a very important issue for us as of now. And out of the tests we have, one is a VIA, which is very, very subjective, and the results are not so good. And about cytology, again, it's very specific, but then sensitivity is very, very low. So again, we have to call the patient, call and recall has to be done. So if we are doing HPV, that's a very specific test. If it's negative, the percentage is very, very less that she has some lesion and the and HPV is negative. So that is why actually WHO is pushing with this HPV testing. So if we are doing HPV, and we have a very big added advantage with this is that self-sampling. So we don't need to call the patients to the hospital which they really don't like. So the ANM collects the kit and the sampler goes to the home, gives it to the patient and collects the sample and brings it to the laboratory, and we get the test, and once they are positive, we then call the woman to the clinic for any other further test. So that is why, because it's a very specific test, so that is why actually WHO is urging on a specific test around 30 to 40 years of age. So that is why actually, and especially in HIV positive, where the HPV progression to cervical cancer is 6 times higher. So we are urging for HPV test for women with HIV at 25 years of age. So I think because of this high specificity, government WHO is urging on this test. Because Madam, Pap smear also misses out cancers. VIA also misses out cancers, but HPV in a lesser proportion.
Yes,
Yeah.
that's true. Thank you very much, Dr. Bhagyalakshmi. Just last question from Dr. Abhijit Mondal.
Yes, thank you. Thank you, madam. I have a question and query. As recently emerging the adenocarcinoma of cervix, which is related to combined oral contraceptive pills also. And combined oral contraceptive pills also protective against ovarian cancer. So how we will counsel a couple while prescribing OCP, routine pap smear or routine HPV testing is required, because it will invariably increase the chances of cancer cervix, and it will also decrease the chances of ovarian cancer also.
Adam will take the answer. She's a question. She's smiling.
This was good.
COC, actually family planning method, every thing has got its own issue. So family planning method, we will just see the medical eligibility criteria, because we will not combine it, because COC, how many use, so it reduces ovarian cancer, it reduces endometrial cancer, it might increase a little bit breast cancer, and the effect is reversible, and it might increase, like the picture is also changed when the patient is on COC or in pregnancy, because you see the cervix is a little bit. So adenocarcinoma, again, what we say that whenever, that's why I say that always a per speculum examination. I think if the medical eligibility, my one clear message to, like, I think it is an answer to your question, that if the medical eligibility criteria is okay, then any couple can choose any choice of contraception. We don't prescribe any contraception to reduce anything risk. It is their choice. They can use anything, LICUD, DIMPA, progesterone. But the issue is that the COC, अगर वो पूछेंगे, हर जना पूछता है, कॉपर टी से कैंसर हो जाता है, COC से कैंसर हो जाता है, always everybody say. तो हमको बोलना, मतलब like we have to be like we, because we don't have the answer also, that किसी को भी कुछ हो सकता है, but that is immediate problem. But it is always per speculum program, per speculum examination should be done, and that's why I a little bit like really cytology with full like 3 plays. We take endocervical brush also, and we have the endocervical speculum also. So whenever you think that the cervix is not looking bad, or she is having even symptom also, so then HPV, I think it may help or it may not help vaccination, but we have that to do with the endocervical breast sampling, as well as a little what use of endocervical speculum, so that we can have like not real targeted biopsy. So it is not that common. I think Bhagyalakshmi, adenocarcinoma is much less common, but in certain section it is there. But I think as all of the professional, we will not discourage a choice of contraception just to prevent or aggravation, because it will preventive also, na? So non-contraceptive beneficial are too much, to reduce anemia and whatnot. So this is my takeaway. Bhagyalakshmi, your comment.
Yes, madam. Because I think we are not using this oral contraceptive for a long time. It's just for a spacing. So we don't give it for a very long time, 5 years, 10 years, we are not giving. Just a spacing thing, I think. So
many people take it for 10 years or 5, but it is, but
yes,
like we have to be there for screening.
Also, yes,
Screening, we cannot omit whether the patient is taking COC or not taking any COC. We cannot omit actually.
Yes, madam, when we tell that, because one of the, what is that? We tell that the patients are not coming to the hospital for screening. But I am really ashamed to tell that women are still coming to the hospital and they are being advised ultrasound. No pap smear is done, and patient undergoes a hysterectomy for a fibroid and comes back to us with the report of cervical cancer. I think we don't lose the chance of a woman coming to your clinic and then missing out on a pap smear. Going to the community is a different story, but at least the women who are coming to us should have a speculum examination and a pap smear before they go for hand immediately goes on the prescription TV scan. So I think before a TV scan, a pap scan is so important.
It is very sad story. Woman has got 100 ultrasound so many times, and one thing is that we should be on the one page. In every clinic, we say that reproductive age women abhi screen nahi hua, to aapko karana hai. All people should say whether it is public, it is private sector, then because jab maine 20 like all long ago, it is 1993 when I purchased first that wo colposcope jab video wala chota sa aata tha magnification. At that time I used to talk too much ki aap smear karaiye. Since 30 years, the generation of families have known that they do smear and they come very voluntarily. Ki unko, they are used to it, their families. And this is where our role comes. Every person will say that smear hona hai, aapko IVF karana hai, smear hona hai, whatever. So everybody will be knowing, yes, TETVEC people are accepting what not, if we are offering what not, any costly technology. But it is should be मतलब like भाग्य this should come. जो हम लोगों का एक क्लास वेरिफिकेशन हो गया है ना कि बेसिक ऑब्स्टेटिक्स तो like it is a declassify हमको करना बहुत ज्यादा जरूरी है, बहुत ज्यादा जरूरी है, because that has become an issue actually. Every obstetrician is it is a science, in-depth science. Every preventive oncologist is an in-depth science. And we must nurture talent so the people come and contribute to this field. And it should be our way of clinical practice. Something, what you say na ki patient बोलती है और हम नहीं करते. So that is very realistic scenario actually. So we find no glamour in it. और अगर हम क्या करते हैं,
we'll have to add glamour to it.
Yeah, we have to add to contraception.
We'll have to add glamour to it.
Contraception, preventive oncology, basic obstetric, emergency obstetrical care. It should be glamorous. It should be maybe paying for private sector, and we should invest in it. We should really invest in it.
Well, very nice.
Home message, I think, from Dr. Sadhna. And this is really, I mean, we must look forward to it. And I think this is the right time to thank everyone for spending their Sunday evening here with all of us. And it was so informative. I think I learned so many new things today. And this, I think, holds true for almost all of us. So
Yes,
I'll
madam.
just now ask Maushami to...
I think full justice to this month of February Cancer Awareness Month on the last Sunday. An evening well spent. So a very interactive and interesting panel. I thank all the panelists and Bhagyalakshmi Madam for such an interactive session, and Sadhna Madam for her time. And we wish all the best.
Yeah, good luck to Sadhna.
Good luck to Sadhna Madam and Suchitra Pandit Madam, as well as Suman.
Yes. A vote of thanks by Dr. Shweta.
Shweta, she's the Secretary of JOGS. Her resume, please. She is a consultant obstetrician and gynecologist, now a private practitioner, ex-senior consultant Medica Hospital, and now present Secretary of Jamshedpur Gynae Society. Over to you, Dr. Shweta.
Shweta, you're muted, I think.
Ma'am, can you please remove your headset and try, ma'am? No, ma'am, I think so. There is a problem in your headset. Can you please remove that, ma'am?
Yeah, Shweta.
Sadhna ma'am and all kindly request to allow me to leave some emergency.
Yes, I think everyone has.
Yes, Dr. Shweta, you are.
Thank you so much.
Yes, thank you very much.
No, ma'am. Shweta, ma'am, you are not audible, ma'am.
You're not audible. Maushami, I think you can please, everyone is now needs to. Like to.
No, ma'am, you are not audible, ma'am.
I'm not audible. Na? Shweta, can you add Maushami?
Yeah. So, ma'am, thank you, Shweta. We can see you, but we cannot hear you.
Yeah.
Yeah.
Or doesn't matter. Okay.
Actually, it's very disheartening, na? When one is prepared to talk and then you cannot. It's very disheartening. So I thank our guests of honor, Dr. Devdas sir, Dr. Ushanath madam, Dr. Suchitra Pandit madam, Dr. Sadhna Gupta madam, Dr. Suman Sinha madam, Dr. Pratibha Rai madam, the chairpersons, the speaker, the guests of honor, the panelists, and Bhagya madam. I also thank all the presidents and secretary of the Jharkhand societies for allowing us to organize this lively conference and a very interactive webinar. And last but not the least, the whole team of SHIELD, from Mr. Stavan, who was with us, his team of artists, his IT team, and last today, Miss Chitrakala. She is there organizing it from behind. So we could not have done this without the support of SHIELD.
Okay, thank you very much.
So much, ma'am.
Thank you, and good night to everyone.